Hello, everybody. It's a great pleasure to have you with us today. And also, it's a great honor to be at this session with Professor Florian Lordig from the University Cancer Center Leipzig. My name is Zorana Maravic, and together with Professor Florian Lordig, I will be your host in this session. I'm here on behalf of Digestive Cancers Europe, which is a European umbrella organization representing 38 member organizations coming from all around Europe, and we support the digestive cancer community. Florian, now I invite you to present yourself.
Hello, Zorana, and dear ladies and gentlemen. It's my great honor to be with you today. And it's also my great pleasure to work together with Digestive Cancer Europe. We have the goal to show you what was shown at the ESMO Congress in terms of relevant data that are influencing practice or may influence practice very soon. And for that purpose, we picked up an important study on localized stomach cancer, which I would like to show to you, and then we can talk about what it means for clinical practice. Before I start, I show you here my disclosures, contact with commercial entities, mostly in the context of education or scientific collaboration. Here, a short disclaimer. And I'm showing you just one study on the treatment, on the contemporary treatment of localized, which means non-metastatic stomach cancer. We have seen some other studies as well, but this study shows you in which direction we will be going. It is a combination of chemotherapy and immunotherapy in the treatment of localized stomach cancer. And what maybe you should know as a background is that when it comes to localized stomach cancer, so cancer which is diagnosed in the stomach without that any metastases are found in other organs, in the majority of cases, we do recommend surgery, but not surgery alone. We also recommend perioperative chemotherapy. This means chemotherapy that starts before the operation is done and is continued after the operation is done. This is a principle that we are following since 15 to 20 years based on large, mostly European studies that have been done in this field and that have shown that the combination of chemotherapy and surgery is needed to improve the survival chances for patients. Nevertheless, it is still a dangerous condition to have stomach cancer, even if the operation went optimal, even if the chemotherapy was administered as planned. Still, many patients experience a relapse and are in danger of dying from that disease. Therefore, a lot is studied now to improve this procedure. And one particularly important improvement might be the addition of immunotherapy to chemotherapy. And this has been done in this study here with the immune checkpoint inhibitor durvalumab in the framework of a study which is called the Matterhorn study. So this is showing you some of the technical details. The Matterhorn study is a phase 3 study. It was done globally, which means many countries, many centers from different regions in the world were involved, Asian, non-Asian. It was a randomized study, double-blind. The patients and also the investigators did not know if the patients received durvalumab or placebo. It's about perioperative treatment with durvalumab and a typical chemotherapy regimen consisting of 5-FU, leucovorin, oxaliplatin, docetaxel, a mixture that we call FLOT. And all this was applied in operable cancer of the stomach or the entrance region of the stomach, which we call the esophagogastric junction. What was presented at the ESMO meeting was not yet the final analysis, but an important interim analysis. I have here a very technical picture of the study flow chart. It just shows you that overall almost 1,000 patients, this is given here, the number, were taking part in the study. And these patients were randomized, which means it was not their decision how they want to be treated, also not the decision of the treating physician, but it was done by randomization. So the machine finally decided if they go to chemotherapy plus placebo, some of the chemotherapy given before surgery, some of the chemotherapy given after surgery, or to the investigational arm where chemotherapy FLOT was combined with durvalumab, the immune checkpoint inhibitor. Some before surgery, some after surgery, and the immune checkpoint inhibitor for another 10 doses, so up to 1 year after the operation. This is showing you what has been presented at the ESMO meeting. When the resection is done, pathologists usually investigate the resection specimen, and they can tell how intensive the chemotherapy or the preoperative chemotherapy plus immune checkpoint inhibition worked on the tumor. We call that a complete response or a near complete response when all of the tumor was destroyed by the preoperative treatment or when almost all of the tumor was destroyed. And you can see here in the green bars that the combination of durvalumab plus FLOT more than doubled the complete response to preoperative treatment, durvalumab plus chemo compared to placebo and chemo. And when you look at near complete responses where almost everything of the tumor was destroyed, it was 27% versus 14%. So we believe that this might be quite meaningful because in other settings, such as breast cancer, this huge difference of response to preoperative treatment finally was also associated with improvement of the prognosis and of the overall survival of the population. It needs some time to report that. You need a longer follow-up, a longer observation period to see if the one group has a better relapse rate or a better overall survival than the other group. But what we see here seems quite meaningful to us, and it's a first, I would say, good indicator that the combination of durvalumab plus FLOT may be the treatment we should go for in the future. We also see some other parameters such as were the tumor smaller in the one group or in the other group after pre-treatment, were there less involved lymph nodes. So there are some more indicators that show that durvalumab plus FLOT was quite promising in this setting. So what we can say today is that the addition of durvalumab to perioperative FLOT for patients with localized stomach cancer or esophagogastric junction cancer led to clinically and statistically significant improvement in histopathologic complete response rate. And the Matterhorn study reported these outcomes, but the primary endpoint, survival, event-free survival, is not yet completed. What does it mean for everyday treatment? Is that already something we can prescribe in daily practice? No, not yet, because technically the study still needs to be followed up, still needs to report on event-free survival and overall survival. So perioperative immunotherapy is not yet approved because the study results are premature. However, I suggest that patients should get treatment at centers where study with immunotherapy are available. And this is the case in many of the big European or even beyond cancer centers where patients can be offered these treatments in the framework of clinical studies, because this treatment is so promising that if there is any possibility, patients should try to get access. The best way to get access is in the framework of clinical studies, where we learn more about the treatments, where the results can also inform clinical practice for future patients, and where patients can be treated safely with this new approach. That's it, what I wanted to tell you about localized stomach cancer. Zorana, I hope that this is more or less understandable from a patient perspective.
Thank you, Florian. I think it's the way you presented this, although some slides were busy, is very understandable. And I think it shows that immunotherapy added to standard therapy in the perioperative setting, so before the surgery, could lead, hopefully, potentially, to more patients being cured. And I guess this is what you as the physician and also the patients are looking for. I wanted to ask you, because this treatment is currently not available, and you highlighted that it could be available to clinical trials. So how do you think clinicians could encourage their patients to seek for clinical trials, or how would you encourage patients to seek for clinical trials? Because as we have seen, this is very important and could bring better outcomes for them.
I think that is an important point. And working in an academic center like I do, actually, we see a lot of patients who are looking for trials, who present in our center because they want to get innovative treatment. I think the main message is that a lot of things are going on in oncology. We see a lot of progress over the last 10, 15 years. New drugs, completely new mechanisms of action, such as immunotherapy, that is now playing a big role. And the safest way to get access to such innovation is to become a member of a clinical study, because in clinical studies we observe everything very carefully. All the side effects, patients report very frequently how they feel during the treatment. We do a lot of safety assessments, such as laboratory tests or imaging tests. So that's a good offer, in my view, that patients on the one hand get access to something that might be better than what we had before, and on the other hand have the safety of being well monitored, not running into any hazards, I would say.
Thank you. Thank you. I couldn't agree more with you. And also another point that I think is very important in the treatment of gastric cancer is the approach to the multidisciplinary team in the centers of excellence, because these are operable patients, but yet you want to administer treatment before the surgery in order to have better outcomes. So it's really important to have this multidisciplinary approach to decide on what is the best treatment for the patient. What do you think, Florian?
I couldn't agree more. And the study which I just showed you gives a very good example for that. Such a study could not be done without the commitment of the surgeons, of the medical oncologists, the gastroenterologists. It's the whole team that must play together. And every discipline gives its contribution. The outcome of patients, the survival outcome, the survival chances of patients with stomach cancer does not depend on chemotherapy alone or immunotherapy alone. In the end of the day, it's the expertise of the whole team that counts. Well-trained teams with a real focus on the disease are usually found in bigger centers, in specialized cancer centers. And the quality of the team is finally the one that makes the difference. And we still see a lot of, let me say, difficulties for patients to approach the optimal team. In my country, we have a certification process for qualified teams. They are audited every year. This is also coming now to more and more European countries. We have European certified cancer centers. And I think that makes sense to go further along this road. And if a patient asks, how do I find such a center? It is the one thing to ask for certifications, such as within the European certification or the national certification process, and also caseload plays a role. It's also important if you treat 10 of these conditions per year or 100. A team that treats 100 is more trained to manage all the complications, all the challenges during the treatment. So that's also something how patients and patient organizations could help to find the right center.
Thank you. I think this is really important to highlight to patients to seek the right center where they should be treated, to have this multidisciplinary approach, and then also to encourage them to participate in clinical trials, because as we have seen in the study that you have presented, they could have a chances to get better outcomes. And I guess that although the results of the Matterhorn study are not there yet, we are still waiting for the survival data. And hopefully this will be positive. And while we are waiting, we can just encourage patients to participate in other clinical trials that involve immunotherapy in the perioperative setting. Thank you, Florian, for this interesting presentation and for doing this in a patient-friendly language, which I hope they understood. And it was a pleasure, as always, to discuss this with you.
Thank you, Zorana. My pleasure.